Hi, this is a video of a glaucoma tube, a glaucoma surgical device placed inside the eye to lower pressure inside the eye. The tube we're going to be featuring in this video is a ClearPath 250. Hi, my name is Mohammed ElMallah. I'm a board certified ophthalmologist. I practice in Central Florida, in Ocala and the Villages, Florida. I share this video in hopes of showing my technique for how to place this tube in hopes that it benefits other surgeons, trainees, medical students, those interested in eye health. On my channel, I also post videos that are intended for patients. This is not one of them. This is intended for other surgeons to show how I place this tube and some tips and strategies to achieve optimal outcomes for our patients. This is a 40-minute video, so I'm going to play it in twice the speed. I'm going to speed it up here, but still be illustrative of all the concepts that I want to illustrate. If you're interested in watching in real time, you can adjust the playback speed on your YouTube player. So the first thing I'm doing here is placing a traction suture through the superior cornea. This has no effect on the patient's vision or long-term outcome, of course, but it does help us orient the globe during the surgery and expose the part of the eye where we want to see what we're doing. So it's a 7-ovical suture. We place it through the superior. It's a 7-ovical suture. We place it through the superior cornea, and then I'm just going to place it around the lid speculum here, and that provides us a nice view of the superior temporal quadrant. I'm sitting superiorly in this case. This is a cornea protector, which I place over the cornea to protect the cornea and keep it from drying out and keep the sutures from maligning or irritating the cornea. And then you see here, we now have good exposure of the area where we need to do the surgery. I make a conjunctival peritomy or conjunctival incision that's approximately 4 or 5 millimeters back from the limbus. I make an initial incision there with Westcott scissors. This is done under topical anesthetic. There is no retrobulbar block here. And then I'm injecting preservative-free block solution in the subconjunctival space. I then use Westcott scissors here to inject the conjunctival incision, and we are now going underneath the tenons, so we're injecting below the tenons as well. I've started making smaller and smaller incisions with this ClearPath tube. It's a much smaller incision than I would make for an Ahmed FP7 tube or a Bearvelt 250 or 350 tube. And the reason that is because, as you'll see here when I come to place a ClearPath tube, is you can fold this tube up and really have it kind of unfold once it's in the subconjunctival space. So Wexel so we can see what we're doing here, and then we extend. What I'm here is I'm extending my incision through tenons, still keeping the conjunctival incision the same size, but by extending the tenons subconjunctivally, we have a greater area of exposure. We may do some cautery here, so I have my assistant place BSS on the field so it can isolate the areas where cautery would be most beneficial. We dissect the subconjunctival space. We dissected posteriorly, which you saw earlier, and now I'm dissecting anteriorly towards the limbus. I use a Wexel sponge to tease the tenons off of the scleral bed. And so we want to go anteriorly here to at least the point where we want to place the tube. This instrument is flat. It's called a Took blade, and you can use it to also do blunt dissection anteriorly and raise and disinsert tenons, as we saw demonstrated here. So what I'm doing is I'm putting the Wexel sponge below the conjunctiva, and I'm reflecting the conjunctiva back over the Wexel sponge so I can see how anterior I've gotten here. So I'm happy with that dissection, and now we turn our attention to tying off this tube. I see many surgeons who will secure the tube first to the sclera and then tie it off. I prefer to do it off of the surgical field on the Mayo stand next to my assistant here. So as you can see, this video is unedited, so you're going to get to see everything that goes along with this. For this ClearPath tube, I like to wrap the 7/0 Vicryl suture, which we're going to use to tie this off. I like to wrap it once around the tube. I found that this has helped me achieve a more consistent watertight closure of the tube. Interestingly, New World Medical, the company that produces this tube, has now come out with a small tube and ClearPath 250 ST, which is a tube that has a smaller lumen. And I would imagine, I haven't used it yet, but I would imagine that it would be easier to tie off and occlude this tube. Okay, so this is a non-valve tube. What does that mean? As opposed to the Ahmed FP7 tube, which has a valve, which can regulate and prevent hypotony, this tube is a non-valve tube. There is no valve here, which means if we place it inside the eye without tying it off, we will get hypotony. The pressure will be too low. And why is that? Because the body has not formed a capsule around the plate yet. So there's very little resistance to outflow. And because the tube has a large lumen, you will get too much outflow, you will have hypotony, and then that will can lead to a whole host of other complications. So when we place these tubes, we like to ligate or tie around the tube with a dissolvable suture. This is 7/0 Vicryl, and this will dissolve, become weaker over the course of about 4 to 6 weeks. And typically after about 4 to 6 weeks, this suture will dissolve, the tube will open. At that point in time, there should be enough resistance to outflow. What I did there was with the BSS, I was testing to see if it was a watertight closure, and in fact it was. Now that we do have a watertight closure, we can go ahead and lock around this tube. You can see my assistant is helping to hold the tube still for me while I place some more knots over the original 3 throws that I placed there. So this is a non-valve tube, so it's important to go ahead and tie it off before we place this into the eye, or tie it off in general at the time of surgery, so we don't get initial hypotony. What that initial 4 to 6 weeks allows the body to do is to form a capsule around that foreign body, some sort of capsule, and therefore have some resistance to outflow once that tube opens up, less risk of hypotony that way. So this is just heme here. We're going to clean that up in preparation for placing the tube. Many surgeons place a ripcord, so quote unquote a ripcord in the lumen, which is a suture in the lumen of the tube, which allows a more controlled opening of the tube in the office. I have found that this requires a secondary procedure. Okay, here comes the tube going in. You can see that what I did there is I just folded up that tube into 3. So I folded each end onto each end down, so it just rolled it up, and then I opened that up inside the subconjunctival space. Not unlike what we do with our intraocular lenses, where it's rolled up and then it unfolds in the space. This allows me to have a smaller conjunctival incision, and we can do that with a ClearPath because the eyelets are more anterior than the plate, and so you don't have to suture so far back from the conjunctival limbus. You can see here I'm measuring 8 millimeters back from the limbus, and the eyelets easily clear 8 millimeters back. The suture holes are approximately, looks here, about 10 millimeters back from the limbus. I use nylon to secure the plate, and we place nylon through these 2 eyelets here. Important to have good exposure for this. The eyelets being more anterior allows for better exposure. What I was saying earlier, as far as placing a ripcord, I stopped placing a ripcord maybe about 8 years ago or so. Often required, oftentimes the tube would open spontaneously, and there really wouldn't be too much of an issue when the tube opened up. And also, required a second procedure, which of course could be done at the slit lamp, but nonetheless with a second procedure for the patient to open up the tube. So I have been comfortable with the 7/0 Vicryl, the single 7/0 Vicryl suture here, just to occlude the tube with no ripcord. So we secured one eyelet. Now we're going to secure the other eyelet. That tube is in the way, and what I did there is actually just place that tube behind the lid speculum to keep it out of the way. So we secured the second eyelet here with 9/0 nylon. I learned that little trick during fellowship, just putting that tube behind the lid speculum. So we have our one pass through the sclera, and then we'll have another pass through the eyelet. We'll secure that. and then we'll turn attention to placing the tube into the anterior chamber. This 9-0 nylon suture is placed in a 3-1-1, and you can see here we're able to achieve this really just through a much smaller incision than we normally would. So we've talked about how this is a non-valve tube. The need to close it off. We talked about how we don't use a ripcord here. Another thing about the ClearPath tube is it has a much, in general, in my experience, it has a much lower profile it creates a much lower profile bleb. Here we're just rotating those knots so that they're not exposed and they don't irritate, or less risk of those knots working through the conjunctiva. So we look at how long the tube needs to be. I often err on the side of the tube being too long. And I used to route all these tubes to the 12 o'clock position to allow for maximum lid coverage to decrease the risk of tube exposure. I really don't do that as much anymore. So I don't really do that anymore. I generally just follow a straighter path into the eye. And now you'll see when I come to place the tube, I do place it in at an angle, not directly into the globe. So this part is actually really important. I do a paracentesis, and this allows me to access the anterior chamber should the eye become hypotenuse. So at this point in time here, I'm just clearing out the path where I'm going to be placing this tube. I pulled on the posterior lip of the conjunctival incision just to bring the whole thing forward because the opening is rather small. And we do see that there's a vessel here. I have my needle already marked by my surgical assistant here, and I didn't go straight into the globe. I actually went a little bit at an angle, so I angled more rather than aiming for the center of the. I'm looking there. I'm just checking the position of the needle, and I see the needle there in the anterior chamber. So rather than aiming for the center of the pupil when I go in, I aim a little bit to the right and towards maybe the mid-iris. So here we place a tube. You can see the tube goes in there easily. That's because I use a 22 gauge needle. Oftentimes with these tubes, you use a 23 gauge needle to get a more watertight closure, but there can be some peritubular flow when you use a 22 gauge needle. So I am happy with the tube there in the anterior chamber. I'm looking and checking the position and the traction suture. I can see that tube is where I need it to be. It's maybe a little bit long, so I pull back a little bit on it there. But I'm happy with where it is. It's not too close to the cornea, and it appears to be relatively flat with respect to the iris plane. So now I'm going to use 9-0 nylon to secure the tube. I often use a mattress suture. Let's see what I did in this case here. So you can see there is some redundancy there to the tube because I did pull it out a little bit. And here is my 9-0 nylon suture. And I am going to be placing here a mattress suture. So we'll just reverse the direction for the second pass. And all I'm doing there is just adjusting the needle against my forceps to get it to be the angle that I want it to be. I've seen surgeons place these a little bit further away from the tube, which is fine. And you can do that when you have more exposure. I've seen some surgeons not secure the tube to the sclera at all. I like the reason to secure the tube to the sclera to consider is because you're probably going to have less risk of tube erosion that way. If the tube is moving around, there's higher risk, of course, of tube erosion. So let's go ahead and just speed this up again. We'll go 2x speed. And so as we suture this, you'll see here you have, when you do this mattress suture, you have 2 points of fixation of the tube. I'm going to tie this down, and then we'll trim the suture, rotate the knot so it's not up against the conjunctiva, less risk of exposure that way. Okay, so there we see that the suture actually ripped while I was doing that. So we'll see here if there's enough there to keep that suture intact or not. If not, it's okay. We'll just pull it out. We'll place it again. But it looks like it's okay there. and it already looks like the knot is to the side. So there is a little bit of redundancy there. Normally I don't secure the tube again, but if there is a little bit of redundancy, I may go ahead and just try and secure that tube at a second point, or I may not. Let's see here. I'm not entirely sure what I'm going to do. So I'm waiting for something. Okay, yeah, it looks like I am going to secure the tube again here. Actually, no, I'm not. I'm just making my venting slits. So there's two venting slits placed there, and I'll check to see if there's any flow through there. Sometimes you'll see the aqueous just percolate out from there, but I'm not seeing that here. And it looks like I am actually placing another. It looks like I am actually going to secure the tube here. I don't usually, if there's going to be that much movement with the tube, I will try and secure it again. I was wondering there if I was going to secure that tube or not. But in any case, I am. So whenever I see movement like that, and there is redundancy, I like to secure the tube in two different locations. That theoretically decreases the risk of tube exposure. Obviously, I don't really have any, control trials to support that, but that is why I place that second suture there. Okay, so once again, rotate the knot, important. We've got two venting slits in place. We've got the tube now well secured, and now we have to place a patch graft. My patch graft of choice is a corneal patch graft. And so we get the half moon corneal patch graft there. I have my assistant irrigate it, and then we place it over the tube. And we're going to use, I often use 7 Vicryl to secure that patch graft, but it looks like in this case we're not going to actually be secure in that patch graft. I may just go ahead and, so often I'll secure this patch graft with Vicryl suture, but sometimes with the smaller incisions I actually don't secure that patch graft to the sclera. When the incision's so small, there's very little place for this to go. Closure. I like to use a layered closure if possible. If I have tenons, which I do here, I'll secure the tenons to the sclera first. And so I'll do that here with a single interrupted suture. So let's summarize here. We have placed the Bearvelt 250. We've tied off the tube. We've secured the tube to the sclera. We have trimmed the tube, placed the tube in the anterior chamber at the appropriate plane and location and length. We've then secured the tube to the sclera, and we've made the venting slits. We've placed the corneal patch graft over the tube. And now we are closing the tenons over the corneal patch graft. And after we're done with that, we're going to close the conjunctiva in a running, locking fashion. Okay, I just wanted to show my technique for placing a ClearPath 250 tube. I'm interested in hearing your comments. If you do it a different way, if you place a ripcord, don't place a ripcord, what advantages you found, how it's helped you, and if you are in training, I tried to make this really as clear as I possibly could, and I hope that this has been helpful to you. So it looks like I've secured the tenons there, and it looks like I'm going to go ahead and run this closure. Just a few comments about the closure. I do a running, locking closure with 8 Vicryl. So once we have tied down this initial knot, I'll trim the suture end and then run the rest in a locking fashion. I'll demonstrate that here as we do this closure. So I pull up on the suture end, I go through both ends of the incision, and then I place it through the loop. I pull it out through the loop, and then I'm able to use that suture end to lock that suture bite, and at the same time raise the conj and invert the wound edges. Oftentimes you'll get a very nice cosmetically pleasing result with this technique. And because it is a smaller incision, we don't have to run it anywhere near as long as what we normally do with other tubes or with a larger incision. So that's actually coming together really very nicely. And then for the final bite here, I'm going to not lock it. I'm going to tie it to itself. And we'll pull both ends here to make sure we have a nice tight closure. And then we do a 2, 1, 1. It looks like I did an extra throw there as well. Trim that with Van Ness scissors. We'll remove the corner of the traction suture. We'll take a look at everything, make sure we're happy with how things look. So we've placed that ClearPath 250 tube. We placed it in the sub-Tenon, subconjunctival space. And we're going to remove the traction suture. We'll take a look at everything, make sure our paracentesis here is watertight. Our areas for the traction suture are watertight. So we can see the tube there. It's hard to see here, but the tube is in, it looks like it's in a good position. And the anterior-chamber pressure looks somewhere between 10 and 15. I'll check the paracentesis there with the Wexel. And that's really about it. That's the end of the case. Thank you for your attention. I hope you found this helpful. Let me know. See you soon.